So yeah, it's an honor to be here presenting at the last talk of the season. I hope to keep it engaging and interesting. I will probably talk for about 40 to 45 minutes or so with some time for questions at the end. And of course, today's presentation is entitled Research Partnerships in Canadian Healthcare, How to Become a Partner in Canadian Health Research. So I would also like to acknowledge that we are gathered here today on Treaty 1 territory, which is the traditional land of the Anishinaabe, Cree, Oji-Cree, Dene, and Dakota nations. Manitoba is national homeland of the Red River Métis, and northern Manitoba includes the present and ancestral lands of the Inuit. I believe that acknowledging this truth is a small but critical step in building stronger relationships with our Indigenous communities, and I respect the spirit and intent of treaties and the process of creating them. So I'm also committed to working in partnership with First Nations, Inuit, and Métis people. Again, thank you, Stephanie, for the intro. My name is Cheryl Ann Moser. My background is in communications, kinesiology, and neuroscience. And then I kind of took that undergraduate degree process and folded it into knowledge translation. So I just recently completed my master's degree. It was focused on knowledge translation in healthcare, kind of touching on all of these different pieces of the things I'd sort of done before. And I'm currently working as a research assistant at the University of Manitoba. So before I really get into kind of the hard learning, I thought I would share a little bit about myself today and why this topic matters and how I sort of ended up down this weird research path looking at things like healthcare reform in partnership with so many other groups of people. For me, it started with my first passion, which was being athletic. I was a runner through and through, one of those people who woke up at the crack of dawn. I brought my sneakers everywhere. They were in the trunk of my car. I was also very sporty. And then as I got older, so late teens, early 20s, I started experiencing a little bit of dysfunction in some of my joints, more specifically my right ankle joint. And so over time, every time I would go for a run, my ankle would let out on me just a little bit. And it was one of those things where, just like anything, if you do something you love and there's a tiny challenge, you overlook it and you find ways to keep working around it. But so ultimately what happened to me was a really rare underlying disease process that nobody in our medical system was equipped to deal with. So essentially, I have a disease that affects the integrity of some of my small bones in my small joints, whereby if they undergo any kind of trauma, so let's say a fracture or a sprain, I'm at risk of damaging the bone to the point where it won't recover and my bone will slowly die over time. So I didn't know that back in 2001. I was still trying desperately to run, but this problem with my ankle failing to essentially support my body weight, and it was very painful on top of it, it became increasingly more frequent and intense. And then eventually it got to the point where one morning I literally went to step out of bed and my ankle would not support my body weight. It just would not hold me up anymore. So unfortunately for me, this was a really poorly understood disease process. It resulted in late diagnostic procedures because nobody really knew what was going on. I looked and sounded like someone who had a sprained ankle a lot, and who was maybe being a baby about it. And so because of that mistake, we didn't know what to look for or when to start looking. So late diagnostic procedures, insufficient diagnostic procedures, so the wrong tests being ordered, ultimately meant almost 3 years of delays in terms of getting appropriate treatment options. So for me, this led to a poor health outcome. My bone in my right ankle ultimately died. There were no sort of ways of recovering that particular bone. And so it affects me to this day, just in terms of strength and mobility, my gait, increased risk of falls as I get older. I mean, again, my story started about 20 years ago, so you can imagine I'm in my 40s now. And this is when these types of changes start happening to our bodies, these injuries we had when we're young. So, and today I have 3 bones, small bones, one in my thumb, one in my foot, also affected by this same problem. So for me, poorer health outcomes, but man, what an interesting story. So for me, I knew that I was definitely interested in medicine and anatomy and physiology and all of the things. But the bigger part for me, I'm a rare case. What I have is not common. I wasn't going to ever make a living solving the dead bone problem on the planet. But I could certainly look at, like, how did this even get to be a problem? Like, why did we not take the right images or do the right things? So ultimately, my diagnosis, what I received was idiopathic avascular necrosis of the talus bone. So this here is actually a scan of my right ankle. That very white part that you can see is the part of my talus bone, so the pivotal bone in the ankle, that lost its blood supply and slowly lost its integrity. The bone died in place. And then over time, over about a decade of life in my 20s to 30, the bone slowly deteriorated and kind of broke away. So I've kind of got an internal joint deformity, I think is what it's called. But so essentially what this means in plain language is I have a problem of unknown cause. That's what idiopathic means. Avascular meaning a lost blood supply, and necrosis referring to death. So of unknown cause, somehow the blood supply in my talus bone got cut off and the bone slowly died over time. So obviously over that, 3-year period, I was very keen to obviously know what was wrong with me. I wanted to get an accurate diagnosis, but the process of getting there is the thing that really fascinated me. So this is just really a Coles Note summary of how things kind of played out over this 3-year period and where it got me thinking differently about healthcare reform. So I had been working at the time, early in my communications career back then, in my early 20s. And obviously, I'm hobbling around at work. People would notice that I'm in discomfort and pain. So a boss of mine was colleagues with Dr. Glenn Bergeron. He was head of the athletic therapy department at the University of Winnipeg, if anyone is familiar with him. But just through this sort of friendly association, he said, okay, why don't you go and talk to him? He sees all kinds of athletic injuries. He might have some insight for you. These were also the days just before the smartphone and right after the internet, where you still had to go to destinations and pay to check your email. So doing online networking was not really very easy. And yet that is part of how we started to solve my problem and a big part of how we problem solve in healthcare today. So Dr. Glenn Bergeron was on the Canadian Olympic team. He was the athletic therapist, the head AT for our Canadian team. He went down to the Sydney 2000 Olympics, where a female sprinter from Australia, she was on the starting block and had the exact same experience I did that one morning getting out of bed, where she got up to go and her ankle just let out, and that was it. She could not get up. That was the end of her running career. The person attending to her was Dr. Jock Anderson, so he's out of the University of New South Wales in Australia. So through this networking with Glenn and Jock, the two of them were able to help problem solve for the sprinter, but then Glenn comes back to Manitoba and meets me, and it's an oh my gosh, a eureka moment. We've seen this at least once before. So ultimately, my bone scans and my case study are included in Dr. Jock Anderson's textbook. So where we did not in North America have a way of diagnosing and treating and solving this problem in a reasonable time frame, those answers were out there. It did exist. Other people have had it, and they've benefited from those early detection and intervention methods. So that's what really got me thinking. How is it in Canada that we know what to do in health or in healthcare at all? which knowledge matters. So, and that sounds kind of like a weird question, but really, which knowledge matters? Which culture has the knowledge that makes the sense that solves the problem? And maybe it's not just one thing. And then finally, what happens when we learn something new? So how does new knowledge translate to changes in Canadian healthcare and improved health outcomes for all of us? That's what led me ultimately to this thing called knowledge translation, which is an action-oriented approach to solving complex problems in Canadian healthcare. And one of the first steps in knowledge translation as an approach to doing research is identifying and engaging with partners. So people just like you. It's really important for folks in Canada to realize that health research is something that is open and accessible for all Canadians. So you're able, no matter your position in life, to join a health research partnership because your knowledge and your skills, experiences in health and healthcare are really critical to helping to guide what we do in innovative problem solving through health research. So that kind of brings to the learning objectives for today. That's my backstory and why I care so much about this, but also how I found ways for people, like I said, just like you and me, to get involved in research. You don't need the degrees, you just need to have a bit of care and some experience that you're willing to share. So the goal of today's presentation really is to increase your awareness and share some information with you about opportunities for clinicians, organization leaders, patients, families, even just yourself as a person in society to engage as a partner in Canadian health research. So I'm going to touch on these 6 areas: what it means to do health research in Canada, why we do health research in Canada, who benefits from health research, who is doing it, how health research is actually done, and then, of course, how anybody in this room or people you know could join a health research partnership and start making a difference. So first of all, what does it mean to do health research? A lot of people, we hear the word research and we feel like we know generally what it means. And I think generally we all do. In general, research is a way of problem solving. It's certainly not the only way, but in health and healthcare, when you're dealing with lots of people with lots of backgrounds and opinions and experiences, certainly research is a really good strategy for problem solving. In Canada, health research specifically is a way of identifying, studying, and solving complex problems in health, but also in healthcare, because we have a healthcare system. So for example, Canadian health research or healthcare research may include studies in any of these 4 general areas. Certainly there are other ways of approaching scientific research and health research, but for the most part, studies in Canada fall into these 4 main buckets of biomedical research, clinical research, health services research, and finally, social, cultural, environmental, and population research. Each of these areas has a distinct and specific focus. So biomedical research examines normal and abnormal processes in the human body using things like molecules, cells, tissues, organs, and body systems. This is pretty much the type of clinical or laboratory-based research that a lot of us would sort of just generally prototype in our brain when we hear that word. And historically, there hasn't been a lot of opportunity for partners to jump in on this type of research, but that's changing. So where partners like you and me would not necessarily be brought into the foray of a lab, where we are being brought in is right at the front end of a study to help define what the problem is we're trying to solve And that helps guide what it is that we're looking at under the microscope and what the implications of what we're looking at are for the whole body and real person. So that's one way partners like you and I can get involved in biomedical research, is really helping to shape the design of those research studies right from the start. Clinical research examines challenges in health behaviors with people. Often when we're talking about health behaviors, we need to know a lot more about what's going on with the person. And we do that with things like surveys and interviews, but we also use biological data and samples. So things like we might ask you about your relationship with food, and we might ask you to keep a food diary. But then we might also want to do blood and urine tests to better identify whether or not those stories are consistent or inconsistent. And then we look at different types of clinical interventions to help problem solve for people. So that's an opportunity, again, for partners like you and I to get involved, to share our opinions, to volunteer to be those people who want to share about our processes and experiences in health. Health services research examines challenges in health systems. So that's kind of where my work has really sat. Well, we're looking at systems, the services that we provide, the policies that are governing those systems and services. And we do that using things like public health data, different types of pilot programs, just experiments, right? You throw a program out there and see what happens, as well as usability studies. So when we think about usability today, we think a lot about technologies, and certainly that's true in healthcare as well, especially when it comes to communicating with providers using things like Zoom or Teams or even apps these days. Then finally, social, cultural, environmental, and population research examines the health of entire communities and populations using things like focus groups with members of the public. We look more closely at public health policies across the board and how those are impacting public behaviors, as well as trends in public health data. So I think we saw a lot of this type of research happening in real time over the COVID-19 pandemic, right? We would implement one public health policy and that caused immediate behavior changes, and some of the behavior changes were desired and some undesired. And that's where you start looking at alternative methods of tweaking policy, sending out public messaging that helps shape our communities in different ways. So why do we do health research at all? I mean, the obvious thing is we're aiming to prevent disease. We want better ways of diagnosing and treating and managing illness. And we do this ultimately by trying new things. Health research also has the potential to improve the quality of life for all Canadians by improving the healthcare delivery system that we're dealing with and the way that all of us access our care services. And ultimately, through those processes, we do get healthier populations and communities. Who benefits from health research? Well, ideally, everyone would benefit from health research. Generally speaking, our personal health, our quality of life, the health of our communities here in Canada is attributed to decades of health research that's really led to a better spectrum of care options, improved access for different groups of people, and a more accessible healthcare system overall. The problem is we know that factors like justice, equity, diversity, inclusivity, and accessibility are all significant, serious barriers for all kinds of people, which means we have a lot of work to do. And that's why this effort towards partnering in research is really ramping up. We've heard too many of the exact same voices for too long, which means we're spending a lot of time and money sometimes focused on problems that a large chunk of the population might say is not a problem. We need to be looking at something else. So that's why it's really important that all of us see ourselves in this research world as opportunities to help. So I was told kind of heading into today's talk that there would be a wide range of people joining. So there might be some of you who are healthcare providers out in the crowd, and certainly there's lots of room for healthcare providers to engage in research. But shockingly, not a lot of healthcare providers see themselves in that role either. So just to share a little bit about those who are currently engaged, they tend to pursue really timely and interesting projects and topics that are driving clinical innovation. So the things that we do with patients or interventions. They're also helping to drive evidence-based change. So doing things that the science says is pretty valid and reliable. They're also helping to provide better access to care and improved patient outcomes, just by virtue of having those healthcare providers on our research teams. Organizations like SCI, so whether you are a volunteer coordinator, whether you are working in marketing communications, whether you have a more technical job or something where you're working with people, it's the organizations that have that proactive effort like SCI to host health research partnerships that are really supporting these truly unique interactions among healthcare providers, patients, families, caregivers, and other key decision makers that are leading to the innovative problem solving that we're seeing, especially since COVID. Really fast, rapid development because the right people are there contributing in the right ways at the right times. And then patients and families who partner for health research are actually guiding the way we explore the human body. It's your body for us to be talking about. It's your body that may or may not have a challenge, or someone you love has that challenge, and we want to solve that challenge. So it's patients, families, and their carers that are really guiding what we look at in terms of the body, disease prevention and management, but really also the issues that people face when they have an illness. And that stems to all kinds of different things in life, right? It's a much more holistic story that impacts on your social life, your financial life, your education opportunities. And it's patients and families that are really the ones driving and changing that narrative. So how health research is done in Canada, generally there are three main phases to each research project that's underway. And each of those phases presents many opportunities to get involved. So one thing to think about is that being engaged in research does not mean that you need to be engaged throughout an entire study, beginning, middle, and end. You certainly can, but there might be opportunities for you to jump in and out of certain projects, or maybe you find that your thing is in jumping in at a certain phase of research, and then you repeat that in a few different studies to see how that impacts on the way we perceive. So for example, the first major phase in research generally is to design your study. So coming up with your research question and figuring out how you're going to investigate that topic, and then you conduct the study. The second phase really is trying study findings in real life contexts. And I think a lot of us have maybe heard or seen recruitment posters like that before, where something new is going out and you're being asked to adopt and give it a go. And then finally, it's about delivering valid solutions to people, such as health products, healthcare practices, and healthy lifestyle advice. That phase of research sits really nicely in sort of this knowledge translation world. So you've completed a study and now you have to tell people about it, because the idea ultimately, if we're moving towards betterment, that means change. And for a lot of us, it's behavior change. So there are many opportunities for folks like you and I to engage in these studies at the very end, when it's time to start telling people the good news that something is new and different and has some validity. So I thought I would share a few examples of my work in knowledge translation that were embedded in these different types of health research partnerships, just to kind of give you a sense of how far-reaching and broad your role could be in these types of studies, and just the types of topics that people are asking us to study. So one of the first projects I had worked on was an oral systemic health curriculum project for the University of Manitoba that was designed to provide access to dental care for those without coverage or without access to community care providers. So we're hearing a fair bit about that in the news lately from a policy change perspective, and I'm thrilled to say that was an arm of this project that took almost 20 years of conversations, 10 hard years at least. But so this was, the health challenge was there were a lot of Canadians who either did not have health insurance to pay for dental care or who lived in really remote places where there are no dentists. And that's actually really common in Canada. Most of our dentists are in very populated urban centers. So we had, and on top of it, it was leading to so oral systemic health problems. So things like cardiovascular problems, mental health problems, colds and flus, systemic infections, chronic states of inflammation. There's links between diabetes and oral health. So we were discovering that by neglecting the mouth and treating it separately from the rest of the body, people were getting sicker, and those secondary things from an oral problem were becoming far more expensive than the province itself could manage. So we started provincially by training physicians to provide basic medical exams and basic intervention in oral systemic medical emergencies. So at least in the field, in remote places where there was a doctor and no dentist, someone would know what to do. So that was kind of phase one, and that part of the project won an award at the American Dental Education ADEA, the American Dental Education Association, which was like the Academy Awards of Dentistry. It was an amazing experience. But it goes to show you, like, it seems like such a simple thing, train a doctor to open the mouth and look inside of it, but no one was talking about it. Nobody was complaining about the problem until we decided to finally do something about it with a government grant from the province of Manitoba. Another challenge we had, so I had worked on a national team. It was funded by the Canadian Partnership Against Cancer, which, if you're familiar with that funding body, they can fund projects anywhere in Canada. So this national project, Moving Forward After Cancer, was a curriculum project that ultimately launched at universities throughout Canada, changing the way healthcare is provided to cancer survivors. So back in the 1980s, if you got a cancer diagnosis, you were likely to die from it. That's not true anymore. Now people can live 5 and 10 years and more after their cancer diagnosis. But what was happening is cancer patients often would receive their diagnosis due to some type of emergency medical intervention in hospital, right? Bypassing their family doctor, the person with whom they have a relationship. And then immediately they're sent to oncology, and so begins this next chapter of life as a cancer survivor. And for those who do outlive their treatment, so the conclusion of treatment, when it's all wrapped up, all your chemo and radiation therapies and alternative therapies, the problem is people were experiencing late and long-lasting effects from both cancer and its treatments. And these were things that the medical community was not equipped to deal with. We weren't used to people living that long after they'd had blasts of radiation and cisplatin chemotherapies and things like that. So we needed a better way of understanding what the challenges were facing cancer survivors and which ones we could tackle first. And it turned out there were some pretty common problems in terms of patient handoffs. So what did that mean for a person? I mean, it would be terrifying to go to a hospital and then you're all of a sudden getting chemotherapy. Your family doctor doesn't know, and you had no one to ask. And up until just the last 10 years, that was exactly how the cancer experience went. And I'm thrilled to say that that has since changed. This program helped train family physicians on what to look for in terms of, like I said, late and long-lasting effects, but also how to work in partnership with oncology. And oncologists learned which information they needed to share back with family medicine to keep everyone involved as a care team for a cancer survivor. So then with the Heart and Stroke Foundation in 2018, we had launched the Women's Heart and Brain Health Campaign, and it was designed to address two major factors, a gender gap, but as well as racial inequities in cardiovascular health research and healthcare. The problem that we were dealing with here was a sweeping change that had gone back from 1968 to 2018, so 50 years. Women had been eliminated from all kinds of health research. The reason women had been eliminated from health research, and this was globally, this was not just in Canada, but of course it's our problem. Women had been eliminated sweepingly from health research because of the thalidomide disaster in the 50s. If you're familiar, thalidomide was a medication used to treat morning sickness in pregnant women and resulted in devastating birth defects affecting an entire generation. So from that point on, women were deemed not to know whether or not we were pregnant. Therefore, we were all considered a high risk for medical research, and we were just not included. So as a result, most disease processes, here we cared about hearts and brains and circulation, but as a result, we knew that women were more likely to die of their heart disease and stroke than men, and were less likely to receive early intervention or follow-up treatment rehabilitation afterwards. So that's a big glaring question. And it was a significant difference between the number of men and women that would survive heart disease or not. So then we're looking at women thinking, why? And so, of course, we were excluded from research, and it turns out that symptoms manifest quite differently in women than in men. There are some gender-based differences in that cardiovascular anatomy that affects the way we anticipate and respond to cardiovascular health in women. But it wasn't all women either. White women tended to be doing all right? But it was all other groups of women, specifically in Canada, Indigenous women, again, living in remote and northern communities with no access to care and no sense of interpreting or responding to cues in the body, and their family members and loved ones wouldn't know what to look for either, because we just didn't ask. We didn't include anyone. And then finally, in this last example, also with heart and stroke, they launched a Community of Heroes resuscitation program. So this is like those pilot programs I kind of talked about, where you try something to see if we can make a difference. So the health challenge we had is that a lot of heart and stroke events occur in the community. Most heart and stroke events happen at public recreation places, work, and school. So these were places where we needed to increase opportunities for bystander intervention, because you have a problem then where if you've got a major event, a medical event taking place in a very crowded public space, you get this distributed responsibility problem where no one wants to do anything. And people also fear I could do something wrong, I could cause harm. So part of this, it was an education campaign. It was also designed to give people knowledge, skills, and confidence to jump in these situations. And we also tried to put the spin on it that, you know, this is probably you're out with your family and friends, and you might be the one called on to help your family and friends. So this was an example of a program that aimed to increase bystander intervention with a new community-based resource program with family-friendly training. We made sure that AEDs were placed in all public spaces and that a registry and maintenance list was attached to those devices so that at least if you find one, you can trust that it might work. But there was also a big education piece in terms of you can only help, you can't hurt, We have a Good Samaritan law that encourages this good behavior, but we also made it really fun. So jumping in these interventions, in a cardiac arrest, doing CPR, it's hard work. It is really physical labor, and a lot of people don't really think about that. So this was a chance to get people doing hands-only CPR, practicing. The biggest consumers of this program were children. It was one of the most remarkable things. It was kids encouraging their parents. And we did a CPR relay. So we had, police and firefighters there. So for kids, it was amazing. But it attracted a lot of the right type of conversation, attention, and knowledge that those resources are in the community and people are more likely. So this program, it spanned 2 provinces, Manitoba and Saskatchewan, and we did increase bystander intervention by, I think it was 4%, which doesn't sound like a lot, but it's a change in the right direction. So it was a pilot program that worked and probably needs a little bit more to keep people engaged. So how can you join a Canadian Health Research Partnership and jump in on some projects just like these? Well, essentially, you can join a team, you can form a research team, or you can submit ideas to existing researchers to get your ideas heard. So the best recommendation I would have for you is to jump online and start exploring some of the Canadian Health Research Partnerships that are currently underway. So given that we're sort of in a child health and family environment, I did connect with a few organizations. I've done work with some of these different groups. So these are really great places to start. I will follow up today's presentation with some tools that provide you with a bit more of that call to action in case you are interested. But certainly here at SCI, the Rehabilitation Center for Children, and then the Enrich Research Program are working really closely together by engaging a family council in research. And their interests are primarily focused on achieving family-centered programming and supports, which most of you are probably familiar with. CRIM, this is another organization I'm engaged with, the Children's Hospital Research Institute of Manitoba, which is the research arm of the Children's Hospital Foundation. It's a lot, but it's the research side. And the research side there is focused on investigating all types of issues affecting the health of pregnant people, families, and children, specifically in Manitoba. And then finally, the Engage Research Program. Some of you might be connected with Dr. Roberta Woodgate. You maybe have heard of either her or her program. This one is led by her out of the University of Manitoba and is focused on investigating the health and social issues affecting children, youth, and families. She does a lot of work around mental health, certainly, but also a lot of work on what it means to be a new Canadian and to find housing security, education, and financial security. These are topics, of course, that are a huge concern to our youth today. And so through partnerships like that, she's exploring topics that are sort of led and guided by her young partners. So that concludes my presentation for today. I hope I've left you at least mildly interested in opportunities to partner in research, and certainly not to just think about it as kind of the work that people are doing at the bench, but everything from telling people what's great, new, and exciting in health and healthcare to being the one that approaches someone and says, why aren't we looking at this topic? I have a question that we need to answer. And with that, do you have any questions for me?